Welcome to the Gynarchy Podcast. This is your host, Dr. Kirti Patel. Here we place women's health and feminism front and center where they belong, engaging in conversations that range from the fundamental to the fearless. With insights from expert guests, we aim to break through the barriers of the patriarchy and envision a new world led by the Gynarchy. So let's get started and dive right in. Welcome to the Gynarchy Podcast. This is your host, Dr. Kirti Patel. Today we're going to be talking all things menopause, and I have a fantastic guest for you, Dr. Sameena Rahman. Dr. Rahman is a board-certified OBGYN, and she also practices, now she specializes in sexual medicine and also menopause medicine. She's a fellow of the International Society for the Study of Women's Sexual Health, and she's also a certified menopause physician with the North American Menopause Society, NAMS. So welcome, Sameena. Thank you so much.
Thank you so much. Thank you so much for having me. I'm so excited about your launch. That's amazing. You're going to kill it. It's going to be awesome.
Well, we shall see, right? But, I just love your background. I feel like sexual medicine and menopause medicine are just things that, just not talked about enough. And so I love that you're specializing in those things, like things that are neglected in women's health. And I just kind of want to know, what brought you to this from practicing? I'd love to hear your story. How you went from general OBGYN to doing this.
Yeah, absolutely. Thank you so much. Yeah, I think that it is, one of these areas that we just don't talk about enough. We don't educate doctors and other, medical healthcare providers enough. And I think there was a statistic that something like 7% of internal medicine or OBGYNs that come out of residency are actually comfortable treating menopausal patients. Wow. It's really low. But anyway, and the majority feel like they need more. So I actually, like you said, I'm a board certified OBGYN. After residency, I moved to Los Angeles and I was on the faculty at the University of Southern California for a while. So I did a lot of education and worked on the faculty, and then moved to Chicago when I got married and worked with North Shore, which is a big healthcare system, and then Northwestern. When I started at Northwestern, I started their OB hospitalist program because I just had a baby. And so I wanted to trying to get, you're trying to balance. And so I did it for a few years, and my husband's an interventional pain and sports medicine specialist. And he had started his practice in 2012, and he had built out the space and everything, and was around 2013. He was like, I'd been working tons of nights. Right. And he's like, I feel like your personality is changing. I was like, you don't seem happy, because it felt like a job after a while. You just feel like
you want to have
job. The passion wasn't there. So he's like, I have this space. I'm not there a couple days a week. Why don't you start your own gynae practice? And I was like, okay, because that's what we learned in medical school and residency. We learn how to start a practice. And this was August 2014. So in the fall, I'll be celebrating 10 years.
Oh, congratulations.
Thank you so much.
It takes so much courage, because we don't see that at all.
We don't learn. And, back then, now there's a lot of social media presence and people that are really encouraging others to branch on their own. But when I started 10 years ago, I went out there and I asked a bunch of gynaes in Chicago that I had been working with in the hospital, any advice? I don't even know where I should get pap smears from. I don't even know from, any of this, but I knew I was going to do gynae only at the time. And nobody helped. Nobody helped at all. They were just and I'm there are literally millions of vulvas in Chicago, and I need 40 to keep myself, 40 a week.
Is it because they didn't know, or they didn't want to share the information?
I think they didn't want to share because there was this weird competitive spirit. I'm because there's gynaes so frequently, and it was just weird. It was disheartening. I did eventually, figure it out a little bit, but
that's really odd to me, because 50% of the population is women, and honestly, there are not enough of us. There's a shortage.
Yeah, they actually just said that there's only 50,000 OBGYNs in the country right now, and in 5 years it's going to be 10% less or something like that. I don't have the statistic exactly right, but there's a shortage. You're absolutely right.
I'm going to tell you something funny. Okay, one of my medical colleagues said, they're just so desperate for doctors in general, but OBGYNs, you could literally be sprung from jail and wearing an ankle bracelet and they'd still hire you.
Oh God.
That's a terrible joke.
That's probably true. That's a terrible
yeah.
joke. But yeah, it's probably true, especially in certain areas like the South where all the stuff is happening.
It's horrible. Yeah.
But anyway, I started my own practice and I fumbled through it for the first few years. But when you start your own practice and you have no practice that you're bringing over, like I didn't have a following because I was a hospitalist. So I was starting really from ground zero.
Wow.
And, the first 5 patients that I had that week got like these 2-hour visits, right? Because I was like, you're my only patient today.
They must have loved that.
And then I realized, it was within that first week that I had my first, it was one of my South Asian patients that had sexual pain, right? So I was like, oh, what do we learn in residency about sex? Really, it's just vaginismus and PT. That's all you ever learn, right? Like you don't really learn any, and even that is like probably all, even for some people less than that. So anyway, I spent a lot of time with her, and then I was really like, how the hell am I going to help her? Because there has to be more to this than what I know. And then I just started researching, like reading my own articles. And then I found actually the Society it's SMSNA. So it's the Sexual Medicine Society of North America. And I said, I didn't, because at that time I hadn't heard of Ishwish. And I was like, oh, let me go to this organization and see what I can learn at their annual meeting. And it was all urology. So it was like 90% male sexual function and dysfunction. But that's where I met Dr. Irwin Goldstein for the first time. And he is, as some of you know or may know, is the godfather of female sexual medicine. He helped to create the field, and he's like, you really need to be going to Ishwish. And I was like, okay. So then I started going to Ishwish and I did the courses, and I've been a lifer at this point. I love the organization extensively. And it's the International Society for the Study of Women's Sexual Health is the premier women's sexual health organization. And that same year, yeah, go ahead.
Sorry. I'm sorry. What year was that you started?
It was going to those? 2015 of it. Yeah. Cause it was like, by the time I figured it out, it was 2015. So anyway, and then I started going to the menopause and got certified and all that stuff that same within a year of that, I think. So that's kind of where I decided to then veer my practice. Although I do still see a lot of other gynae stuff, but
yes. Okay. So do you practice general gynecology plus sexual medicine and women?
Yeah. I mean, I still see, I think probably 80% of my practice is sex med menopause. And then I'll still see some the abnormal bleedings and the, annual assessments and all that stuff. So.
Okay. Thank you so much for sharing that. I'm sort of following your footsteps a few years behind. Sameena and I met at an Ishwish conference, and I'm very passionate now.
Yeah.
I mean,
it's a cult.
Yes, they're my people. I love these women. I meet there, and men, women and men.
Yeah, it was so funny because my husband's like, oh, Ishwish, you guys are like a cult. But we are like, once you feel the fever and you feel the passion, I mean, it rejuvenates you because you're like, I can really help some women and get them through it.
It really does. I mean, it's such a good feeling at this age, this far into my career, to have such passion still for what I chose to do and as a 20-something-year-old. Okay, so the topic at hand, I thought we'd just talk about menopause in general. The reason at first I was going to get a little bit more specific with you, but what's funny is I see every week in the office, there's women coming in who are asking, who will start having some changes in their 40s, symptoms, like hot flashes or periods are off. And they come in asking me is this menopause? Am I in menopause? Is there a blood test? It just struck me as how strange is this? 50% of the population is women. All of us will go through menopause. We live so long, 1/3 to 1/2 of our lives is going to be in menopause.
Yes.
And no one seems to know.
Exactly.
What are the signs and symptoms and when am I in menopause and what happens after that? So that's why I wanted to just kind of make this a general
talk. Yeah. Just heads up, guys. So
why do you think it is actually? Why
I mean, I think it's because we don't educate, because whenever I have a 30-something-year-old, 30-year-old in my office, I'm like, I'm just going to give you a heads up since you have no complaints. This is what might happen in the next 10 years, perimenopause. I tell them the symptoms and they're like, why are you telling me this? Some people are very excited that I tell them, but I'm like, we give puberty talks to kids. We should give peri talks to women, right? Yes. So I make it an active after them to do that. And I think, just so people know the definition of menopause is 12 months without a menstrual cycle. And the FMP, the final menstrual period, is where you describe your entry into menopause. But 7 to 10 years before that, and if the average age is 51 and a half, but you have people between 45 and 55 entering menopause, if you calculate 10 years before that, could be perimenopausal symptoms starting. Some people do start in their late 30s, some people start in their early 30s because one question you always have to ask is, when do you think your mom went through menopause, or your sisters? And, oh, my mom never talked to me about that. I don't know.
Or they had a hysterectomy and they don't know. Right?
Yes. Especially, all the women of color, like, my mom had a hysterectomy.
Yes.
Because, they were taking out all of our uteruses back then. So, I think that it's, very significant to just understand that. But the perimenopausal transition is, of course, where you have the most fluctuation in your hormones. And that's where most people get the most symptoms, right? And so I have a thing I always tell my patients, I think of the big 3 B's of perimenopause, right? So the bleeding starts to change. You'll have people say, oh, I've had a 28-day cycle my whole life, and all of a sudden it's coming 21 days, or it's coming heavier than normal, or it's spacing out more than normal. So that's the first B I talk about, the bleeding. And then brain, right? And brain issues. You have to remember, we have estrogen receptors all over our body, from our head to our foot. So anywhere we have those issues, you can consider a potential change, right? So when it comes to cognitive distress, I think one of the most significant things patients complain about is really brain fog. Oh, I just walked into this room. I don't know. Oh, I had this bagel and it's now burning because I forgot I put it in there. The brain fog is real. And you have to think, in menopause or perimenopause, you might be at the pinnacle of your career, or the pinnacle of taking care of your kids, and we're balancing so much, right? We have older parents, we have, kids that are growing up. It's a real balance for women. And then all of a sudden you're getting your hormones, going on a roller coaster ride with them. And it's really distressing. So I have patients all the time who are CEOs and whatever. And they're like, I was just in the middle of this talk, and all of a sudden I don't remember what my next statement was, so it's can be very inhibiting. But another common complaint, I think, from the brain perspective is really irritability. I have patients tell me all the time, oh, my husband thinks I'm going crazy. I'm pissed off all the time. I yell at my kids all the time. So all of that cognitive distress. And I think there's a 4-fold increase in the number of antidepressants that women get in midlife, because of depression and anxiety. I never was anxious before. Now all of a sudden I am, that kind of thing. So that's the B for brain. And then the third B I always talk about is burning. Okay, vasomotor symptoms, hot flashes, night sweats. That's what most people think about perimenopause, where you get a surge of heat, in your face, or, or you feel like taking off all your clothes 1 minute. So that's the vasomotor symptoms. And then you can have burning in the vagina too, when it feels irritated or dry or pain with sex. This whole, what we call the genitourinary syndrome menopause, which is a progressive chronic condition, because if you're not giving yourself that estrogen back, then that is, something that's just going to continue. But, people have all sorts of complaints, right? There's a musculoskeletal syndrome menopause, frozen shoulder is more common, joints. Everyone has arthralgias.
Another big complaint, which maybe falls in your brain category, is sleep problems. So bad in the 40s.
So bad. Whether or not that's from hey, I'm getting up because I'm peeing all the time, or I get up and I think about the 100 things I have to do, or the hot flashes wake you up. But that cognitive distress leading to sleep disturbances. And we know you need a good 7 to 9 hours to keep yourself metabolically healthy, keep your heart healthy, keep you from getting obese. It makes a big impact. And people always used to say, oh, a hot flash can't kill you. But we know the data doesn't suggest that anymore, that if you have uncontrolled hot flashes, it actually can lead to metabolic dysfunction, diabetes, heart disease, which is still the number 1 killer in women, right? All of that stuff that can, and potentially even early death if you have really, stressed your system with uncontrolled hot flashes.
Yes. I'm so glad you brought up chronic problems, because I think that's another thing that we don't talk about enough. Because sure, menopause just has this hot flash, this, it's just synonymous with hot flashes, and that's it.
It's a natural process. Blah, blah, blah.
Yeah. And I think it's really much more profound than we make it out to be, and important. It's the literal transition to another phase of life, during which we are going to have a little bit higher risks of different things going on. Like you mentioned, cardiovascular disease, but also osteoporosis. And you mentioned metabolic syndrome or type 2 diabetes. You have a higher risk. There's a higher risk of cancer. So a lot of things need to be, we need to be monitoring more. And we need to actually be perhaps treating, whatever.
For prevention.
Right, exactly. Preventative care.
That's good stuff. Yeah. Yeah, it's very true. And for the South Asian listeners out there, Kirti and I always talk about that, like we make up, what is it, like a third of the world population, but like 2/3 of the world diabetes and heart disease. Like it's a profound thing. And so when I have a midlife South Asian woman in my office, I'm like, listen, if you have no contraindications to hormone use, let's talk about, even not only the bone protection, right, which is one of the indications for the use of hormonal therapy in menopause, but let's talk about the cardioprotective effect, and how it might, help you not get, cholesterol issues or get those, plaques taken care of, that it does have a cardioprotective effect. And we know that, heart disease still kills all women, but South Asian women particularly, like we know that it's a big burden. So, I'm in there trying to advocate for the brown girls too.
That's awesome. I love it. So, I feel like, I read this crazy statistic that like 70-80% of women suffer from symptoms, but only like 20 to 30% seek help. And so that kind of bothered me. And then just today, a friend sent an article saying that 3/4 of women, they knew I was doing this podcast. So they sent this article saying that 3/4 of women in the workplace say that it affects their productivity, their menopausal symptoms. So I'm like, what is going on with the disconnect with not seeking treatment? Is it because we're just taught to suck it up, or is it because they just want to go a natural route, or are they afraid of hormones or what we may offer? There are non-hormonal treatments too. So what do you think is going on?
I think it's all of the above. I mean, I always say menopause is having a moment now. So, obviously, like there was a big article in the New York Times last year that women had been, or maybe 2 years ago, women have been misled about menopause. It was a really viral article talking about. And then, there was another article about a Mayo study that was done talking about the economic burden of menopause on the workplace and how much, I can't remember the exact $1 billion now, but like the $1 billion loss in wages, in, productivity and all of that. So there's a big burden of, what happens. I mean, and I think there's underlying patriarchy. We know that, right? Like women are told to, like, I have patients that are literally telling me, like, you're the third doctor I've seen. Doctors are telling, or, any clinician, whether it's a PA or a nurse practitioner or whatever, have told me that I should just suck it up because this is a natural process, that you went through labor, so this shouldn't be so bad for you. Just BS comments that no one would tell a man if he had all of his testosterone removed. And they lose a lot of testosterone in their midlife, and no one thinks twice about replacing their testosterone.
Oh yeah. I mean, it's a big fucking emergency. If men are in distress.
I mean, you can get Vioa for like $5 and, none of the sexual medicines for women are even covered half the time, especially for postmenopausal women. So like you have to pay for it.
Like you were saying, I feel like the pendulum has swung back and forth, I still remember my mother being on hormone replacement, and then I was either in med school or starting residency. And
you said, get off of it, Mom.
I know. I was like, oh my God, I have
the Women's Health Initiative.
I have been recommending this, and I have increased the risk of my mother having cancer, and it was scary. And I got her right off. And then now and then in the decades in between, as an OBGYN, I have been recommending alternatives like SSRIs or gabapentin, and then come to learn, the SSRIs have sexual dysfunction, and but now we're swinging back to using hormones. And I guess I wanted to ask,
because we have more long-term data on it, I think too.
Yes. So actually, that's something important to talk about, and I also want to talk about like your approach. So the data, how has the data shifted now? Like the approach now has changed, right?
Well, I think it has, it's very much changed. I think what happened is, some of the data was prematurely discussed. So like Dr. James Simon, he's like, he's the menopause whisperer. He taught like when I first started at Ishbush, he taught me everything to know about menopause before I even went into this stuff. But he actually probably knows the most about menopause than anybody that I've ever met. But anyway, he gives this lecture on how like the government and the media had a conspiracy against women because he talks about this big announcement that was made. We're going to stop the Women's Health Initiative right now. And we're going to because there's this increased cancer risk. And it was like a 911 emergency. And as the data started, as we started seeing more and more data and realizing that this wasn't, as significant of a risk as expected, not more than drinking alcohol or whatever, but nobody made this 911 announcement. It wasn't on Good Morning America. It wasn't all over the CNN news, right? So there is this whole idea of like, okay, the FDA plus, these media outlets really did push the narrative against hormone therapy, and estrogen is now the enemy, because, even though heart disease is going to kill a woman before breast cancer, that's still like what most people get the most scared of.
Right.
So I think that the data, we have more data that shows that, women's longevity diminished when they came off of hormones. There was more heart disease, and so I think, and looking at that, there's a lot of nuances. I won't go into all the details about the Women's Health Initiative, but we know it was, a specific type of hormone therapy. It was Prempro. It was an oral conjugated equine estrogen with a synthetic progesterone, which is not what we use for the most part anymore, which is a great actually medication. I shouldn't say that, but that was the one that was exclusively used and talked about, and how it showed like this, slight bump in breast cancer, which wasn't as significant as people, imagine. And I think that there's you're looking at the estrogen alone arm, there's a decreased risk in breast cancer and all this stuff. But all of that aside, I think it was all of that push around it, and the media push around it, and the government push around it, that really stopped us in our tracks. And this was 22 years ago or something like that.
Right.
So, but there are people that are still practicing, and we have tons of data since then that shows its efficacy and safety. So I think it's important to talk about like who shouldn't take the hormones, like what are the true contraindications to hormone use, and who should take the hormones. And then really what we talk about within the Menopause Society is it's a really nuanced approach, right? We don't practice cookie cutter medicine in sexual medicine or in menopause medicine. We take people's backgrounds into consideration. We take their family history. We take everything. And then you have a discussion with the patient, right? If a patient tells me, I'm a very big proponent of hormones, but if I have a patient, despite giving them all the evidence that it is safe and effective for them, and they still don't want to take it, I'm not going to shove it down their throat,
Right.
But I'm also not going to deny someone hormones who should be on them because they have these uncontrolled hot flashes and night sweats, and and that's compromising their cardiovascular health. So
I love that point you made. Just women are, we often infantilize women in society. Women are intelligent people, and you can just tell them the risks of, well, these are the risks and benefits, X, Y, and Z. And like you said, everyone has different backgrounds. Some people are more comfortable than others with taking hormones. And if they decide that little bit increased risk for them, given their family history or whatever else, and they are comfortable using it, we should prescribe it,
Right.
I get the impression now that it's a little bit more, it's acceptable. And, as long as the patient doesn't have contraindications, that hormone use can be very beneficial actually in early years,
perimenopause,
menopausal years. And it's a little bit more controversial after 60, right? And it's not really recommended.
Right. And so, there used to be this whole timing hypothesis that you have to do it within the 10 years of, within 10 years of menopause. And, because the thought is like, if you've gone through 10 years without, estrogen, then maybe you already have this negative effect from your brain to your heart to everything else, right? The cardiovascular effects are still there. There was a study that just came out like 2 weeks ago, I think, in the Menopause Journal, of looking at women who were over the age of 65. Because there's some women that like tell me, you're going to pry this out of my dead cold hands, Dr. Rahman. So like, but it's like it is a nuanced approach, right? Yeah, you have the same thing.
I wanted to ask you that, what your approach is there, because I have patients who've been on it for years and they turn 60 and then I'm like, now what?
Yeah, what I do? I calculate their ASCVD, American Society of Cardiovascular Disease, has a calculated risk factor that you can use up until age 65. That risk factor is good. And then it's really a mutual discussion, like, okay, so you haven't had any heart disease issues. You're up to date on your colon cancer screening, your breast cancer screening, mammography, all that stuff. It's looking good. Like,
how do you feel about this?
How do you feel about it? Are you still on board or you're not, And so it's just a nuanced discussion, and patients know that. But this study that came out 2 weeks ago showed that even women over the age of 65 that were on estrogen alone had decreased colon cancer, decreased breast cancer, decreased lung cancer, decreased cardiovascular. So it was like still seen as
amazing.
A benefit.
And so, I hear, besides all of that, I also hear that it may have a protective effect against Alzheimer's and dementia.
Right.
But we're waiting for more data, right?
So yeah. So I think Alzheimer's is pretty good. The data around Alzheimer's is pretty good, that, these amyloid plaques occur more frequently in these estrogen deprived brain. I just got Dr. Mosconi's book called The Menopause Brain. So I'm looking forward to reading that. But she is this amazing neuroscientist who talks about how your brain remodels after, and we have this remodeling that happens after estrogen deprivation. Why is it that Alzheimer's is so much more common in women than men? Yeah. And so I think
fascinating.
Right. I think like all cause dementia, you can't say that it's protective against yet. I think the data is still conflicting on that. But I think that, Alzheimer's, there is that potential protective effect. And according to the Menopause Society guidelines, when it comes to what are the reasons they say that you should go on hormones? Of course, the biggest one is around vasomotor symptoms, right? If you have a family history of osteoporosis or osteopenia, or, you're really worried about your bone health, because the reality is if you have an 80-year-old that falls and breaks her hip, her chance of getting, of death from a hip fracture within that first year is profound. Right? Yeah. And so I think that, that is a very profound statistic to discuss that, along with the fact that the genitourinary syndrome of menopause is one other reason to be on hormones. Vaginal estrogen, I always say, is life-saving for patients, right? Because we're not just treating vaginal dryness, right? It's the UTIs. And so I always give an example of how I've had patients that have been on estrogen in their 80s and they come off of it for one reason or another. Maybe they forgot to put their estrogen ring in. It's every 3 months. And, they develop, all of a sudden develop these UTIs, and then they get urosepsis. And then they end up in the ICU. And, a percentage of, I can't remember the exact statistic, 15% can die within that urosepsis evaluation or something. I have to remember the exact statistic. But it is a risk of death from a UTI,
Yeah, exactly.
And we know that it's totally preventative with vaginal estrogen, which the majority of women can be on without any concern. So, those are the big issues around, the people that should be on hormone therapy. And then it's other nuanced, right? Okay, you do have vasomotor symptoms, but you're really concerned about your musculoskeletal syndrome of menopause or whatever. I have this discussion with patients, but those are the guidelines and how we interpret them. And then, like I said, vaginal estrogen, and then systemic estrogen, which is estrogen alone if you don't have a uterus, and estrogen plus progesterone if you have a uterus. So those are all important things to consider. The contraindications to systemic estrogen use, that means that people that we really have to think twice about, are people that have active breast cancer, people that have, active heart disease, active liver disease or end-stage liver disease, people that have undiagnosed vaginal bleeding in postmenopause. You shouldn't put them on hormones yet until you can figure out why. And then unprovoked blood clot in the leg or pulmonary embolus, right? Those are the true contraindications. And even that can be nuanced for some patients. We really have to dive deep into their history. And again, we call it precision medicine. You have to really discuss each patient's individual concerns and tailor it to their needs.
That labeling is also on vaginal estrogen. I see this push on Twitter. I think, do you know Ashley Winter? She's a urologist. She just posted it. Yeah. Yes, I love that. I love that we need to try to change the labeling because vaginal estrogen is not absorbed in the bloodstream like oral estrogen, and it shouldn't have this labeling black box warning. Yes, with all those contraindications, because like you said, it is life-saving. Like an elderly woman with genitourinary syndrome of menopause, which puts you at risk for those frequent UTIs, they need it, or they're gonna, you're gonna get drug-resistant bacteria repeatedly treating them for UTIs.
Yep, or get sepsis, right? Urosepsis. It starts in the urine, but it ends up in your bloodstream, right? And that's when people start getting real bad issues. But absolutely.
Since we're on this topic, I'm thinking, for the patients that have contraindications, right? They have estrogen receptor, breast cancer, they've been through treatment for that and it's contraindicated. What's your approach? You can't.
I mean, I have a discussion with them, and I will have a discussion because I have patients that, are BRCA positive and they're 10, they got diagnosed in their 30s. They went into menopause in their 30s. And then now they're 45, 50 in remission and whatever. Maybe they've had a mastectomy. Maybe they've had their ovaries out, whatever. But I talk to these patients all the time because there is a really important book called Estrogen Matters by Dr. Avram Blooming and Dr. Carolyn, I'm blanking now, but you can put it in the show notes. But basically, they talk about, he's an oncologist who's treated breast cancer patients for a very long time. And he talks about, we need to maybe reconsider the idea of like this contraindication for these breast cancer survivors, because they really do feel left out of the equation. So I will have a nuanced discussion with them if they're remote, if I can, some of my patients are no longer seeing oncologists anymore because, they've had their breasts removed.
Right.
Yeah. And so like, what about them and their heart disease? What about them and their bones, So I think it's worth having a nuanced discussion with them as well. You always have to bring, even when it comes to vaginal estrogen with breast cancer survivors, even though it's, majority of the data does confirm that it's safe, I always have to include the oncologist in the discussion and see, present the data to them and see what they think, and really with the patient as well, because I think that, I have patients, for instance, that like even go into premature ovarian, have that premature ovarian insufficiency where they get into menopause before the age of 30, and maybe they had a remote history of a blood clot in the past. Like, should those patients live, potentially 50 years without estrogen? Yeah, that's not fair for them either. Yes. So, I mean, definitely like have these discussions. Like, make sure we get all the data right. Oh, you said you had a PE, but did you really? Was it provoked? Was it unprovoked? What is the data behind your history? Even, so it really does become these. That's why these discussions can't happen in a 15-minute visit, right? That's why you need time to talk to these menopausal and perimenopausal patients. But I mean, there are some patients like, okay, they don't want to be on it. They can't be on it. So you look at alternatives, right? Like if we're trying to treat the hot flashes and night sweats, there's the newer medication Vioa that is out.
I wanted to ask you what your experience is. I've been counseling patients, but her insurance didn't cover it, and it was very expensive. And then another one, she changed her mind about it. So I don't know. It's a brand new drug. I'm not in a menopause only practice, so I'm offering it as patients come in, but I'm kind of curious about your experience.
Yeah, so it works at the level of your brain. It's a non-hormonal therapy for vasomotor symptoms or those hot flashes and night sweats. Its brand name is Vioa. And so it actually, and you guys probably have seen it because they've had a big push during the Super Bowl. The last two Super Bowls, they've had commercials on it. But it works on the level of, so if we think about our temperature control being at the base of our brain, this works at the level of the neurotransmitters, because there's a fine balance of estrogen in your neurotransmitters when it comes to thermoregulation. So when your estrogen levels go down, this one neurokinin goes up. And so inhibits that from going up. And so then it reduces your hot flashes and night sweats. So I've had actually pretty good experience with this for patients who don't want to be on hormones. They've done really well with it within the first week. They have been able to get a coupon or something for it, or their insurances do cover it over time if you like do a PA and all that stuff. I think that, you have to kind of watch their liver functions, and there's like this whole, how it's digested in the liver, how it interacts with your liver enzymes and what medications they're on. You got to look at that carefully too. But the patients that I have on it are like getting for sure like vasomotor relief, and they're sleeping at night. And so that's improving their metabolic function.
Okay, that's good.
So there is, I think, some benefit to this medication. There's going to be newer ones coming out, I think, as well. So I think it's a good way for us for the patients that really, either don't want to be on hormone therapy or can't be on hormone therapy. I think it's a good alternative.
I think it is just nice to have more options. It's good to finally see another drug FDA approved for this. It's just frustrating how neglected women have been historically. So I do hope there's more options coming out and better efficacy. I have a lot of patients, I don't know if you see this, but a lot of people who just want natural, holistic remedies. And, besides the usual, temperature control for your room and having fans and cool attire and diet, exercise and things like that, like, have you found any herbal remedies that actually work? I've recommended black cohosh and soy.
No, and even if you look at the Menopause Society guidelines on sort of non-hormonal therapy, some of those, are like mid to low level evidence of supporting it. I always talk to patients about, why they have this, fear of hormones if they really have severe vasomotor symptoms. they'll try like an estrogen or something over the counter. I think, so many people are so anti big pharma because they're like, oh, big pharma and whatever. But what they don't realize is like the supplement industry is incredibly unregulated, and
That's
it's a $1
true.
billion industry too. So you're looking at you're looking for something natural that's unregulated and untested. And so, I mean, some of these medications over the counter, like an estrogen or some, these phytoestrogens or whatever, really are just like, supposedly going into the estrogen receptors and activating them or whatever. And I think if someone gets it over the counter and they have a few good months of treatment, that's fine. I find a lot of them may have 6 months of good treatment, and all of a sudden it wears off because the placebo effect is gone.
I also say something similar to patients. I say, well, these things aren't regulated by the FDA. We really don't know the quality. They can have contaminants, but, I encourage you to try, whatever you'd like, but I would put a time limit on it and don't do multiple things at once, or you won't know if it's working or not. Right. And then, make a note of how you feel. And then if 6 weeks, 8 weeks go by and you don't feel any different, it's probably doing nothing.
Right, exactly. And I think there's some role for cognitive behavioral therapy and this kind of thing. Like there was that really upsetting article that came out in the Lancet about how we're over medicalizing menopause, and it was written by and so they talk about some of that, and it's like really just, okay, if you're telling someone to do CBT over cognitive behavioral therapy over hormones, then you're just re-emphasizing that it's all in their head.
Yes. That was such an awful take. Over medicalizing menopause. Didn't you just see these other statistics that women are not going for real symptoms they're having?
Exactly. That's why we were so all of us were so upset about it, because we're just like, it's hard enough for a woman to come forward with her symptoms because she thinks she should suck it up and it's natural. B, to find someone to actually help them and listen to them is a challenge in and of itself. And then C is like the medical system in itself, insurances and healthcare systems don't make this accessible to women either. So they have so many things against them. And here you guys are supposed to be these menopause experts saying the same damn thing,
Plus, sure, you're minimizing these really horrible symptoms. Probably, I'm not sure if it was a man or woman who wrote that, but
they were women. That's even more upsetting.
Horrible. Yeah, but they're minimizing these symptoms that really do affect quality of life and productivity and the economy. But even if you don't,
and life expectancy. I mean, there's some women, right? Like they just don't.
I mean, the bigger thing is menopause does increase your risk for all these diseases we were talking about: osteoporosis, cardiovascular disease, diabetes, metabolic syndrome, dementia. And so you're basically saying it's not important, let them die.
Yeah, exactly. Like
strange.
It's very upsetting. I mean, obviously everyone is affected by, these transitions differently. And so there are patients that are like, oh, I didn't really have any of those symptoms. And wow, kudos to you for that. Right. Like if you really had no symptoms.
I mean, but sure, that's a minority, right?
Very small minority. Yeah. So, I mean, I think that we shouldn't push the narrative back 20 years. That's something we should not do. And it's not fair to women at all.
No, I guess we've talked about basically, vasomotor symptoms. We've talked about genitourinary syndrome of menopause and vaginal estrogen. And then I guess the only other thing I kind of wanted to touch upon is sexual changes, health changes in menopause. And, I guess, it's associated with lower desire, lower, vaginal dryness, pain with sex, and maybe even difficulty with orgasm.
Yes.
So I guess what's your approach with that?
Yeah, it's definitely all of the above. I mean, midlife women are among the most that experience, low libido with bother, which is hypoactive sexual desire disorder. I always say our brain is a sexual organ. And so there are all these things that can put us into excitation or inhibition mode. And for some patients, they're okay having a low libido or whatever, right? But when the low libido starts to bother you, how you feel about yourself, starts to impact your relationship, that frustration around it, that's called hypoactive sexual desire disorder. And this is one of the times, if you think, I always talk about how your, menopause is the time your ovaries are going to retire, right? You're going to quit making estrogen and progesterone. But guess what? Your ovaries make about 50% of your testosterone too. So the other comes from your adrenal glands. So for a lot of women, that loss in testosterone, which is a very important hormone for women and gets like genderized by, society as a whole, with that loss of testosterone, they do have a diminished libido, diminished arousal and orgasm. And then you have to think about all the genital urinary changes locally to the vulvar and vaginal area, right? The clitoris gets smaller, the vulva gets smaller, the labia minora gets smaller, the tissue gets thinner, right? You're not producing the collagen, you don't have those fibroblasts and the precursors for collagen anymore. Your vaginal microbiome is out of whack because your vagina goes from acidic to basic. The vulvar vestibule, that thin area of tissue between the inner labia minora and your hymen remnant and your urethra, that thin area tissue is a very unique area tissue, has both estrogen and testosterone receptors. You need both to make that place healthy. And so for some patients, it becomes very thin and red and inflamed, and the urethra becomes very enlarged and prolapsed. And people get these symptoms of pain with this initial penetration. And that pain with initial penetration, because of that vulvar vestibule, can actually lead to issues around, pelvic floor dysfunction and pelvic floor hypertonicity. So a lot of patients do need that vaginal estrogen. Actually, I think the more superior drug for genital urinary syndrome and menopause, and most people in the sex med world probably would agree, is vaginal DHEA, which converts to estrogen and testosterone. Okay. So you get it at the vulvar, and a study by Dr. Goldstein showed that it really trickles down into the vestibule too. So you can get that estrogen testosterone applied to the vestibule as well. And so, you have that. So that produces the pain with sex, which then sometimes can just contribute to the low libido. Mm-hmm. Some people have no pain with sex. They just have the hypoactive sexual desire disorder, which is one of the indications by our guidelines to use testosterone replacement in women. And the issue at hand really is that we have even though the studies have been there and we have tons of studies on it, the FDA has never approved a testosterone for women. So there's no government, and there's only one government in the whole world that has a testosterone approved for women, and that's Australia. It's called Androfeme. But for everyone else, we have to try to do this like alchemy thing where we titrate male testosterone for female dosing. And this is where I think the predatory market around compounding and pellets and all that stuff that can be dangerous for women. I mean, some women do really well with super therapeutic doses of testosterone. Mm-hmm. Other women will get, abnormal bleeding, precancer. They may get, a deep voice, a clitoris that's enlarged that might bother them or might not bother them, might get hair loss or hair on the face.
Right. Androgenizing effects. And the big concern is they are sometimes not reversible when you stop. So
right. For these and we're speaking specifically of like pellets or injectables that some patients will find a way to get. But what we talk about is using transdermal testosterone gel is what I usually prefer. So I usually prescribe a male FDA approved testosterone for women. And the way I usually do it is I talk to them about getting these tubes. Like a man uses one tube a day. And for a woman, we need 1/10 of that. So she might use, and if that tube has 5 cc's, you might use a half a cc or really a pea size amount. You rub it on the back of your thigh or your knee, or you're not care about hair growth, sorry. And most patients do really well with that. We watch the testosterone levels to make sure we don't get like super physiologic and they don't have any negative side effects. And with that small dose that we titrate to, most patients do really well. But if by 6 months and you're on it, you don't see a change in your libido, then you can discontinue it. But we know that there's probably secondary effects, maybe some effects around energy and muscle and bones and all that stuff too. But for now, the guidelines are around really that I want to have sex, but I can't. So that hypoactive sexual desire disorder. And then, there's sex therapy. We always talk about a biopsychosocial approach to these patients. So there's sex therapy. There's you're looking at the relationships itself and all that stuff. I always say, I can't, if you hate your husband, then I can't help your low desire. I can't extract it.
Cannot fix that with a prescription.
Yeah, exactly. You might have, but yeah. So, yes. but I think it's important to mention testosterone replacement in those patients.
Thank you. That is a really great introduction. I feel like that is an entire podcast in itself.
Yes, we should do one on just sexual dysfunction in the menopause or something.
Yes, I hope you come back. Can you please, I think this was wonderful. I really appreciate you doing this with me. Please share with our audience where they can find you.
Yeah, I'm on Instagram as Gyno Girl, GYNO Girl. Also, I have a YouTube channel called Gyno Girl TV, and I also launched a podcast this year called Gyno Girl Presents Sex, Drugs, and Hormones. and then, just on Facebook and whatever too. But yeah, no, but this has been great. I am so excited for you, and I can't wait to see this explode for you.
Thank you.
Hopefully.
We shall see. So
Okay.
I want to just leave with a closing thought. I think that we need to, I call this the Gynarchy because I feel like so much of the patriarchal society has brainwashed us into thinking that, what's valuable about women is their youth, their virginity, their fertility. But that is not the truth. Okay. The truth is that we women, just like men, gain value with age and in menopause.
Yes.
Like we're more intelligent, we're wise,
Yes.
we're attractive, we're still sexual.
Yes.
We have so much to contribute to our families, our communities, our societies. Our value only increases. So let us have pride and speak about the menopause with pride and, yes, exactly.
Yes.
Without shame.
Right. You're not putting us out to pasture.
Yes. It's not pre-death. We shouldn't be silent about it. We should embrace it. So, and I have a little motto. Down with the patriarchy, up with the Gynarchy.
Yay! I love it.
Thank you so much for joining me.
Of course. Thank you for having me.
Did you enjoy this episode of the Gynarchy Podcast? Know someone else that might enjoy this conversation? Make sure to subscribe and share the show with your friends and family. Find us on Apple, Spotify, YouTube, and just about anywhere you find podcasts. On social media, we can be found on Twitter, Instagram, and TikTok at The Gynarchy. Thank you so much for listening.